Hello, my name is Paul Robinson, and I'm going to be talking to you today about medical emergencies in eating disorders. MEED is the acronym. First of all, I'm going to give you an introduction, and then I'm going to take you through bits of the document, with the MEED document, to introduce you to parts of it. I can't give you all the information, it's about 180 pages, so I'm just inviting you to have a look at it. But I'm going to introduce you to what you'll find when you have a look in there. Okay, let's kick off then. Okay, so this is the sort of problem that we're trying to address. This is a young woman, Avril Hart, who's been very extensively documented, whose progress and sad death has been very, very comprehensively documented, and you can see the investigations that were done in her case on the right, bottom right. There were 2 mental health trust investigations. There was an acute trust. In other words, the medical unit did an investigation, the medical trust. The university did an investigation because she was at university at the time. And there was subsequently, partly as a result of the pressure and the campaign really by Avril's father, a report by the ombudsman, which was extremely important, and then another coroner's report because the case was reopened, and a further coroner's report was issued. So extensive documentation, so we know exactly what the investigations found. And I've just picked out one aspect of it, which was the fact that she was admitted to a medical ward with a very low BMI, 10.8, and the glucose level was low. She wasn't fed for 4 days while abnormal liver was investigated. She was then transferred to another medical ward where the blood sugar was even lower, less than 2 millimoles per litre. This was unfortunately left untreated because it was thought that it was the machine was at fault and not the fact that her glucose was so low, and she died in hypoglycemic coma. There are a number of lessons from this, and we do address this in MEED. You can have a look at the different areas, but first of all, if you suspect an eating disorder, and there was no doubt that she had an eating disorder, she'd been in treatment for over a year for her eating disorder, so diagnosis was not in doubt. So if you see malnutrition due to a severe eating disorder, you have to feed the patient immediately, and any other investigations need to be done in parallel, not sequentially, not before. In any case, liver enzymes are often raised in severe anorexia nervosa because the body is doing its best to get calories and nutrition from anywhere it can, including the liver, and that damages the liver, and you get raised enzymes in blood. Hypoglycemia is quite complex in severe anorexia nervosa because the patient can be completely alert and appear completely fine, even though they have an extremely low blood sugar. And the reason for this is that by the time the blood sugar is low, all the glycogen in the body, which is the chemical which supplies glucose to the cells, that's all gone. What you are surviving on is metabolism of fat. Now, fat produces something called ketone bodies, and ketone bodies are able to be used by the heart and the brain. And this is why someone with an extremely low blood sugar, which if it was caused by another reason, such as, for example, an overdose of insulin, the patient would be unconscious. But in this situation with anorexia nervosa, the ketones are keeping you going, and you can still have a very low blood sugar and also appear okay. However, there's a limit to that because there's a limited amount of fat in the body. And when that gives out, that's when the patient, I think that's when the patient dies. We don't know exactly. Anyway, hypoglycemia does need to be treated as an emergency. The best treatment in general is food. Although in this situation with severe hypoglycemia, and especially if it's symptomatic, if the patient is drowsy or whatever, they probably need an injection of glucose, of high potency glucose. So lots of lessons from that case. This all started, it was called MARSIPAN originally, which stands for Management of Really Sick Patients with Anorexia Nervosa. And I was asked to appear on stage at the BAPEN conference in 2008. BAPEN is the British Association for Parenteral and Enteral Nutrition. And a physician presented this case, which was very similar to Avril, who was admitted after having been in an eating disorder service, and they were unable to treat her because she was so ill. And so she went into a gastro ward. And they were unable to get on top of her eating disorder because she was sabotaging her treatment, because she was terrified of weight gain. The family were in disarray, arguing with each other, and all sorts of problems between the family and the team. And unfortunately, the patient slipped through the net that was allowed, and ended up dying on the medical ward at the age of I think 17. So I was, I mean, I did comment on it, but I was really outraged by the fact that this could happen in this day and age, in the 21st century. And so I got together with the physician who presented the case, who was very affected by it and upset by it. And we got together a group of physicians and psychiatrists, and we also had dietitians and carers involved in the original write-up. And we wrote a document called MARSIPAN, which the aim of which was to give advice to people like physicians and GPs and people in what was then called A&E, and how to deal with somebody with anorexia nervosa who is extremely underweight and who can't be admitted to a psychiatric ward because they are too ill, and so ends up in a medical ward where the staff don't know how to treat her, or him for that matter. So that was the aim. A young person's version for under 18s is slightly different priorities, actually, in the younger version, came out in 2012 called Junior MARSIPAN. And we revised the original MARSIPAN in 2014. And then some years later, I was asked to consider a further revision. And so we produced what ended up as MEED, Medical Emergencies in Eating Disorders. And this was launched on the 19th of May this year. And that's going to form the bulk of this presentation. Okay, the current issues about marzipans. There's certainly more awareness of eating disorders among clinicians, especially psychiatrists and pediatricians. There has also been more awareness in adult medical physicians, although I would say that the response there has been less than in the other groups, and sometimes been quite disappointing. But nevertheless, there has been activity. And when we were producing MEED, we had tremendous support from the emergency medicine and the gastroenterology, especially nutrition group. So this has been a real change, and it's been very robust. And for that reason, we're hoping for a change in uptake, and that there'll be fewer cases, because there still are cases, unfortunately, like this. So, as I said, fatal cases continue to be reported from the medical units well after publication of MARSIPAN. To tell the truth, they're also reported from psychiatric units and also from GP locations. So the problem is everywhere. The fact that anorexia nervosa and other eating disorders, they're relatively uncommon. The severe cases, let's say, and so people don't have much experience of dealing with them, and so also they're really not taught well in medical schools up to this point, and so that's where the problem really begins. And just in the last year, there's been concern from a coroner about eating disorder deaths. And so we wanted to make the guidance, the new MEED, relevant to all royal colleges so that they would be accepted by them. And there was a call for an all-age document, and this is basically what we did. So first of all, there was a leadership group, the project group. This was myself, Dasha Nichols, from child and adolescent psychiatrist, and Agnes Ayton, the chair of the college eating disorder faculty. And we worked together with the NCCMH, which is the National Collaborating Centre for Mental Health, who were commissioned by the Royal College of Psychiatrists, and we're very grateful for that. The NCCMH used to write NICE, mental health NICE, they don't anymore, but they're an extremely competent group, and they kept us to task. And but although we were the main writers of the to tell you sort of how everyone contributed. And then outside that group, we had quite a large expert reference group, which was 16 members from the Royal Colleges of Medicine, Pediatrics, Psychiatry, and Emergency Medicine, as well as dietitians and 2 experts by experience of an eating disorder and 1 carer. So just back to the project group, this was the NCCMH. They conducted systematic reviews, and we all together wrote a draft document. They also liaised with the Royal Colleges to make sure that we were complying with their required procedures for official guidelines. We wanted this to be completely accepted as an official guideline, a bit like NICE is almost always accepted. So then we sent it to the ERG to review, and they had lots of comments, and we discussed things with them. We had meetings with the ERG, that's the expert reference group, and made the various changes they suggested. And then eventually we got to a draft document, which was circulated to a larger stakeholder group, which was of 29 organizations, including charities such as BEAT and FEAST, and medical groups, including the Royal Colleges, and also the British Dietetic Association, also, and the British Psychological Society. All sorts of relevant groups made comments, and they did make comments, and I'm really pleased they did, and they really have improved the document. Only organizations were able to register as stakeholder groups, but as you see, a large number did. And I think most people who needed to be giving us information were able to. So just what happened to produce MEED? First of all, the name, the experts by experience and several professional groups didn't like the name MARSIPAN. they found it belittling and too anorexia focused. It certainly is anorexia focused. And so there was a strong opinion favoring change. And we avoided a complex acronym and went for the brief MEED, which is where it stays. We combined marzipan and junior marzipan to create an all-age guidance. And lastly, the diagnoses, we extended the guidance to all eating disorders, because any eating disorder can be dangerous. Much of the content is similar to marzipan, which if you've read that, you'll notice similarities. But there are important differences. It's an all-age document now. It has a new traffic light RAF, which is risk assessment framework. It's with 3 traffic lights, as opposed to 4 in the junior marzipan. We reduced the number to the usual number of 3 traffic lights. There are literature reviews and guideline comparisons within there. And there are summary sheets, one for each constituency, including one for each emergency department staff, and also for patients, and or rather experts by experience or sufferers, and also their supporters or their families. And there's a brand new section on type 1 diabetes and eating disorders, now known as TIDE, rather than diabulimia, which has now mostly been dropped in favor of TIDE, which I think is a great move. So first of all, I'm going to end this bit of the talk, but with some summary and conclusions. So treatment of eating disorders in non-specialist settings can be very challenging, and collaboration between psychiatric, which is either eating disorder or liaison, but occasionally community psychiatric, general psychiatric services and medical services, is essential to avoid more deaths. So working together is probably the key thing that we want to promote. This new guidance offers advice for clinicians with younger and older patients, and it has a traffic light system that you should be used as part of a competent clinical evaluation. It's not a tick box exercise purely. And we hope that the Royal Colleges will accept our work as official guidelines. I mean, that hasn't happened individually with each of the Royal Colleges, although the Royal College of, importantly, child's pediatrics and child health have accepted the guidelines, and also have the Academy of Royal Colleges, which is an overall body covering all Royal Colleges. So we're doing well from that point of view. And we hope that our new guideline will be used to avoid the unacceptable deaths that continue to occur amongst our patients. So you can join the discussion. There's marzipan. Send an email to marsipanandmeedrequest@gisquail.com, or just write to me at UCL. So part 2 of this talk is more detailed, and here we go into assessment and treatment of adults with eating disorders in the emergency department. But it applies to medical wards and also to primary care. I'm talking primarily about adults because that's my main area of clinical expertise. There will be other talks given about management of children, although I might have a few comments to make about that. As I said, MEED is endorsed by the Academy of Medical Royal Colleges, and there's their logo. So the first question that one needs to ask oneself is, faced with an eating disorder patient, say in the emergency department or in primary care, is how ill is the patient? First of all, bear in mind that eating disorders have the highest standardized mortality of any mental illness, and that includes schizophrenia and depression, both of which have high rates of mortality. The reason that eating disorders have the highest standardized mortality is that patients with eating disorders who die tend to be young. And so when you standardize for age, that increases above the other disorders. So have a look at the risk assessment framework, which is table 1 in MEED. Have a look at the MEED checklist, which is in the appendices in MEED. And that gives you an idea of what questions to ask yourself when you're faced with someone with an eating disorder. And we're developing an app for MEED, you'll be pleased to know. It's not out yet, but we're commissioning it. We've got funding for it, and we hope by, let's say, middle of 2023, the app should be designed and created and available. This is the checklist, which you'll find on the website of the Royal College of Psychiatrists, but also as part of the MEED document. It has 3 bits: assessment, refeeding, and management. And for example, does the patient have an eating disorder? Yes or no? If not, if you're not sure what to do, request a psychiatric review. So it's got questions to ask yourself in all areas that we think are relevant. So use this if you're someone who's on the front line, or indeed if you're, say, a therapist who's faced with someone with a severe eating disorder. You might want to use this to think about whether this person should be medically reviewed or even admitted to hospital, all those things. So don't say, you can't, because you're not medical, you can't separate yourself from this, because you will be held responsible if someone comes to a therapy session and then leaves and then comes to grief afterwards, partly held responsible. So first of all, the traffic light framework. It's the risk assessment framework, the RAF. It's all age, so traffic light, red, amber, and green. And these are the areas to assess: weight, BMI, and rate of change of BMI, cardiovascular, including pulse, BP, and electrocardiogram, temperature and hydration, biochemistry and haematology, muscle strength, eating disorder behavior symptoms, such as engagement with the treatment, exercise and purging, self-harm and suicide. So any red risk on the RAF needs overall clinical evaluation. So if someone has a red risk anywhere, they have a low BMI, they're losing weight quickly, they have a low temperature, any of these things, make sure that there's a full medical evaluation to make sure, so that the patient is properly assessed for their risk. And as I said, we are commissioning an app, and we have got funding, and it'll be in due course. I know not early enough for everybody. So just talking about weight and BMI, you'll know that the WHO normal range for BMI is 18.5 to 25. So look at the absolute level. If it's less than 13, that's a red risk. If it's 13 to 15, that's an amber risk. And if it's more than 15, that's a green risk. You'll notice that it's not normal, the over 15, it's still underweight, and you can still have severe anorexia nervosa at 15, but you're not at high risk of collapsing and needing admission to hospital. That's what it means. Doesn't mean there's no risk, there's lots of risk. So look at the rate of change as well. Is it more than 1 kilogram a week? Is it 0.5 to 1 kilogram a week, or is it less than 0.5 kilogram a week, which gives you the different risk ratings? You'll notice that the risks are not absolute. It's not really like a traffic light, in that you really can't not stop at a traffic light when you're driving. Whereas if someone has a BMI under 13, say someone has a BMI of 12.5, on this rating they'd have a red medical risk, being MEED risk. But if they've had a BMI of 12.5 for the last 15 years and have continued to work and have a family life and do other things that they want to do, then clearly they're not at high risk of collapsing, because they've proven that. So have a look at the rate of change and the other things which might actually put them into a high risk level. So the other thing to mention is that whatever weight the patient is, even if they're not underweight, losing more than 1 kilogram a week, even if you're obese, can be a high risk. I know that some patients who are on very low calorie diets will be losing at that rate, but they can get into medical trouble, and so they should be risk assessed if that's happening. Now, be aware that, and I'm sure you are aware, that patients may falsify their weight, but for example, drinking water, a lot of water, before being weighed. So the answer to that is to use other measures to assess their nutritional state, as well as BMI. Don't neglect BMI, but use these others. First one is cardiovascular health. A pulse rate of less than 40 is worrying. A blood pressure of less than 90 systolic. That's if the blood pressure is 90 over 60, say, the top figure 90 is the systolic. So if they have a low blood pressure, systolic blood pressure, if they have a large drop in blood pressure when they stand up, of more than 20 milligrams of mercury, that's significant as well. The ECG, you can see all sorts of abnormalities. There I've given you an example of a patient who, in the top ECG, has an inverted T wave. That's the right-hand wave, which should be upright, and it's below the surface. And after 2 days of refeeding, look what happens to the T wave. It becomes normal and upright. And also you can see that the heart rate has increased as well. The temperature, less than 35 degrees auxiliary. The hydration, which is acute fluid refusal or signs of dehydration, which you need to take account of. Some of these are things which would only be clear when you're doing a medical examination and also doing some investigations. So muscle strength testing, this is quite important and quite an important thing to do, especially if you're not sure that someone is giving you an accurate weight. So there's the SUS test, which is, I don't know if I'm stuck in the way in your view. There we are, get me out of the way. The left-hand one is where you lie the patient flat on the floor and sit them up. They sit up and then lie down flat again. And the other one is they're standing up, they squat, and they stand up again. There's a scale which you can find in MEED, and also a YouTube demonstration of how to do this test, which you'll find at that YouTube address. It happens to be my daughter, who doesn't have an eating disorder, I'm very pleased to say, but has demonstrated this test very expertly. The second one we use is the hand grip strength. You have to buy something for this, and I must say that one there, which is the one I got from Amazon, it wasn't that expensive, and it's a good measure, but partly because patients quite like doing it, they don't mind doing it, whereas they're not that keen on the SUS test. If you're doing it every day and it's going down, whereas the weight is staying the same or increasing, then that's evidence that the weight might be falsified. The third one you can do, you can choose which one you want to do, is the mid-upper arm circumference, so widely used in dietetics. You find the point of the shoulder and the point of the elbow, measure between and take the halfway point and take the circumference of the muscle, the biceps muscle at that point. And less than 18 is thought to be a highly significant level. Then there are psychological and behavioural aspects. Engagement, for example, a patient who's resistant to any treatment which involves weight gain is at higher risk, and they might be struggling with parents or with staff, physically struggling. Eating behaviour, acute food refusal, for example, less than 500 calories a day for 2 or more days, that increases the risk. Frequent and extreme exercise, frequent and vomiting, frequent laxative abuse, they all increase the risk. And then there are the predictors of suicide, such as suicidal thoughts, suicidal plans, and self-harming behavior, all have an increased risk of completed suicide. And remember that in patients with anorexia nervosa who die, 1 in 5 die from suicide. Now, here's for people who are interested in biochemistry and haematology. The hypokalaemia, which is low potassium level, is probably the most dangerous change. Less than 3.5 is abnormal, and so you should make sure you repeat that. And less than 3, you should consider admission. If you treat them in the emergency department, make sure the patient is reviewed and blood taken within 2 to 4 days. If you see them in A&E and treat them with intravenous potassium and discharge them because the potassium is normal, make sure they're reviewed and the blood taken, the blood is reviewed within 2 to 4 days. And make sure there's follow-up by an eating disorders clinician. Hypoglycemia, which I mentioned before, the patient may be conscious because of ketones, as I said. Abnormal liver function, which is normal in starvation and just needs to be monitored, only if it goes out of control and suggests the possibility of liver failure, which can happen, but it's very rare, should you do any more investigations. The other electrolytes, low sodium often means water loading, which sometimes can present with status epilepticus. In other words, patient water loads more and more, and eventually the sodium goes so low that the patient has a fit, and that's what brings them into hospital. Low bicarbonate, this is due to alkalosis. The body becomes alkaline due to the loss of acid from the stomach, or due to vomiting. Often there's a low potassium. There's a low magnesium in laxative abuse, and also can happen in the refeeding syndrome, and low phosphate, which occurs in the refeeding syndrome. In the refeeding syndrome, somebody who's been starving for a considerable time and suddenly gets a whole lot of carbohydrate, and the cells suddenly start getting energized by the glucose that's around now, and they very quickly suck in magnesium and phosphate and potassium, which can lead to low levels of magnesium, phosphate, and potassium in the blood, which can be fatal. And then there's hematology. In severe anorexia, you can get bone marrow failure with anemia, petechiae, that's small hemorrhages in the skin due to low platelets, and leukopenia, which is low white cells, and that's called pancytopenia, which means all the cells are reduced. Okay, I'm going to show you in MEED some of the ways that the information is presented, and these are snippets only, just a taste. So first of all, there's something that we've called box 1, which is one of the tables, one of the boxes in MEED, and which are potential challenges to accurate risk assessment. First of all, the patient can appear well, and don't take that as reassuring. They often do. Because of the drive to exercise, they may be active up to the point of collapse. as that patient, or rather that person, that woman who's running when she's obviously very underweight. Suicidal ideation and behavior are common. Bloods are often normal, and that's not necessarily reassuring. We've had so many patients who've been discharged from hospital because their bloods were normal, but they've subsequently died from, say, low blood pressure or cardiac arrhythmias, all sorts of problems. And also, just to say, don't reassure the patient that their risk is low, because you can provoke increased restriction and vomiting and exercise in someone who is desperate to be thinner and thinner, and they know that that a low risk means that they're, in their mind, they feel too fat. So the other thing is that fear of weight restoration can reduce the patient's ability to give an accurate account of their history. In other words, they might underplay certain aspects because they're worried about being admitted to hospital and possibly made to gain weight. So this is the risk assessment framework. You can see the red, amber, and green. And just as an example is weight loss, recent loss of weight of more than 1 kilogram a week for 2 consecutive weeks. Recent loss of weight of 0.5 to 1 kilogram a week for 2 consecutive weeks. Recent weight loss of less than half a kilogram a week. So there we are. I won't go through everything that I'm presenting, showing you here. This is table 2, which is how to manage the abnormal findings. So, for example, if you find a low heart rate, or you measure the heart rate, look for a low heart rate, look for increase in heart rate when the patient stands up, and it tells you when to be concerned, and it tells you how to manage that situation. So we hope that'll be helpful. And light bulb signs we've given. Here's the checklist of light bulb signs. I mean, this is only one of them. So rapid weight loss, more than 1 kilogram a week for 2 consecutive weeks. That's an absolute a light bulb sign, which you should be taking notice of. So psychological symptoms, body image disturbance, anxiety and depression. So especially self-harm and suicidal ideas. So we've got a table which gives you an idea of which sort of unit you should be referring the patient to. Say you're in A&E or you're in primary care. Should you refer to a specialist eating disorders unit, assuming you can find a bed in one, which these days is very difficult, or should you be referring to a medical unit? There are certain things that we distinguish between specialist eating disorder units, where the whole unit is an eating disorder, and specialist eating disorder beds, where one bed in a unit which might have other patients with different problems. And that could be a general psychiatric unit with 1 or 2 eating disorder beds. They can normally offer nasogastric feeding, daily blood testing, daily ECGs, and frequent nursing observations, whereas they don't usually offer intravenous infusion, artificial ventilation, or cardiac monitoring. So that will give you an idea of what sort of unit you should be looking for, what sort of bed you should be looking for. So this is table 6, which is management of refeeding. This is a way to approach refeeding, and here's 2 examples of what's in that. So you first do a risk assessment, look at see whether there are any red ratings, and consider the management of each risk factor. You might have to consider employing a one-to-one specialist nurse, but do make sure they know about eating disorders. Other area of concern might be you're not sure of the diagnosis, and there may be non-eating disorder possibilities. such as Crohn's disease or diabetes. So you do investigations rapidly to rule out the alternatives, but don't delay nutrition. And the alternative diagnosis, such as the diabetes, may be in addition to the eating disorder. So here's some ideas about the biochemical results. This is what happens in refeeding syndrome. You get low potassium, low phosphate, low magnesium, and there are other features which are in this table. So this gives you an idea of the features of refeeding syndrome. And some factors associated with the risk of refeeding syndrome: extremely low weight, prolonged low intake, deranged baseline electrolytes, low white cell count. And I would add there, I mean, this is only part of a table, but I would add there sepsis, such as pneumonia or any other form of sepsis. It gives you a higher risk of refeeding syndrome. And this we've given, I won't give in detail, but we've given a refeeding protocol where we divide people into low or medium refeeding syndrome risk and high refeeding syndrome risk. And the high refeeding syndrome risk has a more conservative approach to refeeding. But we do emphasize that even though you may start with low calories, you should increase the calories rapidly while you're testing for refeeding syndrome. And if it happens, then you may have to decrease a little bit. But don't leave somebody without any nutrition for days and days because you're worried about them getting refeeding syndrome. That's a potentially fatal way to treat somebody. And vitamins is another area which are tricky. We tend to give them rather than not give them, because people with eating disorders such as anorexia nervosa, but also ARFID, avoidant restrictive food intake disorder, and also bulimia nervosa tend to be deficient in various vitamins. So we tend to give a multivitamin tablet, but particularly interested in replacing thiamine, because if you don't replace thiamine and then you start refeeding, you can trigger what's called Wernicke's encephalopathy, which is a potentially fatal condition due to thiamine deficiency, and it's something you really want to avoid. Okay, what about the families? We've got a table giving some do's and don'ts for families and carers. For example, do get your own support, do ask to be involved in treatment, but don't talk about diet, weight, and shape with the person with the eating disorder. There's some examples there. There's quite a few. Have a look at this table, table 10. And then how to help, written for carers, but also relevant to staff. So be sympathetic to the person with the eating disorder, who is, after all, experiencing terrifying bullying thoughts and should not be blamed. This is really important because often we find our patients are stigmatized by staff who admit them to general, but also actually to psychiatric units. It's pervasive. So it's the stigma associated with mental disorder, which is unfortunately shared by people with medical degrees and nursing degrees and qualifications. So lastly, compulsory treatment. We've got a decision tree for compulsory treatment about when to consider it and what to do, and when you can't, what you can and can't do to people. So that's, we hope, will be useful. So lastly, this project has been running since 2010. It's now 14 years, and tragically, patients are still dying needlessly. Although, as was pointed out to me recently, almost certainly a large number of patients have not died and have done well because many people have taken note of the guidelines. So I've got the Churchillian quote here. This is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. And I'm hoping our app will provide some acceleration of this process. So I've given you the address again: Marsipan and MEED request at giscmel.ac.uk. And that's it. Thank you very much for listening.